welcome to beautiful Saratoga Springs on this absolutely stunning late summer slash, I guess we have to say Indigenous People Summer Day. And we're glad you all made it here to Saratoga Springs. And we hope those of you who had an opportunity to stay overnight or who will be staying overnight have an opportunity to enjoy all that Saratoga Springs has to offer, which of course is, not inconsiderable. So in any event, welcome all. My name is Art Cooper. I have the honor of chairing this committee at your request. And we are here for the September 16th meeting of the Committee on Emergency Medical Services for Children of the New York State Department of Health. First and foremost, of course, we need to take proper attendance, and we will do so following an official call to order, okay? Which is now officially called to order, so welcome. Amy, do you want to call the roll?
Thank you, Dr. Cooper. Dr. Cooper.
Here.
Dr. Vanderyak.
Here.
Dr. Albert.
Present.
Bruce Berry.
I'm here.
So just for reference for the mics, only two can be on at a time. So, Sharon Chiamento.
Here.
Dr. Conway is excused. Dr. Pamela Foyer.
Present.
We have some new members. They are both excused for this meeting because their appointments came late. So Dr. Kim Wallenstein, who has been our representative from STAC, has been officially appointed as our pediatric surgeon. She is excused. Dr. Vincent Caleo.
Present.
Doug Hexel is also excused. Nicole O'Toole.
Here.
Dr. Bombard. Dr. Harris.
Present.
Chief Pataki.
Present.
Jason Haig is excused. Ben Casper.
Present.
And then one of our other new members who will be in the PEDS critical care nurse seat, Jennifer Falgiatano, who I believe is watching at home. She is also excused. And we have met quorum.
Thank you, Amy. So now, following the agenda, you'll see the next item is approval of the minutes from our May 2024 meeting. These were sent out some time ago electronically. I trust that everyone's had an opportunity to review them. That being said, do I have a motion to approve the minutes?
Motion to approve.
Thank you, sir. Dr. Harris, a second.
I second it.
Thank you, Chief Pataki. And Dr. Vanderyacht, are there any additions, deletions, or corrections to these minutes? Well, hearing none, then all in favor, please signify by saying aye.
Aye.
Aye. Opposed? Okay, the minutes carry without dissent. The next item on the agenda, of course, is our opportunity to hear from the always prepared and up-to-date Amy Eisenhower, who will bring us the EMS-C grant report covering numerous items, as you can see on the printed agenda. Amy, please.
Thank you, Dr. Cooper. We'll start with the Always Ready for Children Pediatric Recognition Program. So that covers hospitals around the state of New York. And we've had a multitude of submissions from all across the state, which is very exciting. which also means there's a little bit of delay reviewing them because it is me reviewing them. And we have some transition in our trauma program, so trying to get them up to date, and we're getting everybody together. So if you have sent an application, you haven't heard back from me, you don't see it on the website yet, it's in process. We have received it, and you'll be hearing more from me soon. If you are interested in the Always Ready for Children program, you can go to our website, so New York State EMS for Children. There is more information there on how to become an Always Ready for Children hospital, and then also more information on pediatric emergency care coordinators, both for in-hospital and pre-hospital. The next part of my agenda is the National Association of State EMS Officials over time has been working on pediatric restraint device testing, and the advisory group finalized their recommendations for SAE, which does crash testing for ambulances and devices in ambulances such as stretchers. So they submitted their recommendations to SAE, and now they're reviewing it and will send back their comments. So while the meetings are not currently active, that information has been submitted, and we'll hear back soon. The EMS for Children Data Center over the summer had their pre-hospital readiness project survey. So similar to what we've been surveying hospitals for, focusing on education, equipment, policies, et cetera, the EMS survey transitioned to a similar survey this summer. And I would like to take a moment to thank our pediatric emergency care coordinator, Allie Lynch, for kind of heading that and making sure everybody got the information for the survey, adjusting emails, checking things, going through the list, coordinating other people to call agencies, and do all of the heavy lift on our side. So thank you so much, because really, honestly, I could not have done it if you did not help me. And then also, much thanks to the other Bureau members that assisted and helped, and the other student assistants in our office that helped us with a lot of phone calls and reaching out to EMS agencies. So there are quite a number of people that make these surveys happen, from EMS-C Federal through the EIC to the EMS-C Data Center themselves, putting the survey together, running things, and then each state office also has a big part. And I'd like to thank all the EMS coordinators across the state and the program agency coordinators across the state that also helped us reaching out to their agencies and sorting out all of that information. So thank you all for making it a success. So across the United States, we had about a 46% return rate, which sounds much different than last year, but this is the first year of this type of survey. And I know that in the future, this will be available also for EMS agencies at emspedsready.org for you to complete in interim years. So once you get your scores back from this year, if you have completed the survey, you get those scores back, you want to check it again in 6 months, 12 months, 18 months to see how your projects are going. You're still able to do that just like hospitals do. That's exciting. The EDC is cleaning the data, and I anticipate in the winter that we'll have some fact sheets for nationally, but then also for New York State data from the survey. Dr. Vanderyak.
Yeah, I just wanted to note, my understanding is also that there will be a survey, readiness survey for the inpatient pediatrics as well, but that's also in the works. So this is EMS, ED, and now it's going to be pediatric inpatient as well. So that's, there's a committee apparently on that as well that one of our faculty is on, so.
I might just add to what Dr. Vanderjagt has said, just in the sense that, the federal EMS-C program envisions EMS-C as covering the entire gamut from prevention through access through, pre-hospital care, then emergency department care, critical care, acute care, and finally rehabilitation. So there's nothing that is really outside of our purview as long as it applies to a child who presents anywhere to anyone anywhere with an emergency medical condition. So it's entirely in keeping that the EMS-C program would, federally speaking, would be interested in an always ready for children approach for the in-hospital side of life as well, recognizing, as we do, of course, that the only way children get to the hospital in order to get treatment for their emergencies is if our pre-hospital colleagues and our prevention colleagues have done the outstanding job that they always do. So just keep that in the back of our minds. So kudos to all of our pre-hospital colleagues who have, over the years, picked up the banner of being always ready for children, and we thank you for that, and especially the children of New York, thank you for that. Okay, anything else, Amy?
A few things.
Please.
So yes, as I said, that information will be coming out this winter. Mentioning Always Ready for Children, so the whole Northeast region, many of the EMS for Children programs in regional pockets of the United States often work together and help each other, and much like we did with the hospitals program, putting together kind of like a keystone program and then making it specific to each state in-state, we are doing the same thing for pre-hospital agencies. So that is underway. The first meetings have occurred of us discussing the requirements that are set forth from EMS-C Federal, how to best achieve those, what processes are already in place for pre-hospital providers, and kind of having those discussions on getting started. So I anticipate that more information will come to you in the next several months. So that is very exciting. Also, shortly, and I'm not sure, Ryan, do you want to include hiring in your report? Or okay, so as many of you know, at the last meeting, it was announced that I have moved to be the Vital Signs Conference Coordinator. Still assisting with EMS for Children, though, still being a part of the program. Well, there's benefits, and I'll get to that in just a hot second. But we will be hiring for the EMS for Children program manager shortly. We are putting that paperwork, the job description's been approved, it's gonna go through HR. So I anticipate that coming out soon. So maybe by next meeting, we will have a new program manager. Well, I will still be here. I'll still be here. Yes, I will still be here helping. Allie will still be here. Jacob will be here. It'll be great. So we're building the team. And leading me to Vital Signs. So the Vital Signs Conference will be in a few short weeks. That's the oh my God part. So in a few short weeks, so starting on October 16th with our pre-conferences, so National Association of EMS educators will be doing their IC1 course. If you haven't registered, there is some pre-work, so register soon so they can send that to you. We also have a leadership class. We have Rochester Fire and many other public service agencies in Monroe County are doing a rescue task force class where there are hands-on skills and evolutions. So that sounds very exciting. We also have NAEMSP is doing 2 pre-conference sessions, one of them being their quality course that is usually in very high demand. I'm trying to run through the list in my head. There's a bunch of pre-conferences. Please go online and check them out. Also, the ALS, BLS pre-cons, so if you need to recertify, we do offer those core classes in a 2-year continuum. So if you attend 2 years in a row, you get most of your core content for your recertification. Those still have some seats open. And then, of course, the amazing pediatric content, which I know is what you're all interested in. So we have an OB assessment class. So Jay Rodriguez from San Antonio, Texas, who's a paramedic and a doula, just did this class at EMS World, and we're lucky enough that he's going to be coming here to New York and doing it here for us in one of the pre-cons. It's a 4-hour class, so you get all of that stuff you didn't really get in your EMS class, but then you get to do some hands-on skills and assessments with actual models who are actively pregnant. So you'll get to, do some skills assessments there. We also have University of Rochester, their pediatric trauma program is going to do that afternoon a separate pre-con for pediatric triage, and it will be a variety of an evolution of stations, of some gamification, so there will be video gaming. There will also be hands-on with actively putting out tents and tarps and all of that. And then some tabletop exercises. So that also sounds like it'll be exciting. And we have many, many pediatric and OB classes out the weekend, including one on pain management by our own Dr. Harris. So very exciting, a lot of great peds and OB content throughout the weekend. And that's the end of my report. Does anybody have any questions?
I don't know how we couldn't have any questions for this report. There's so much to it, but then again, maybe Amy has answered every possible question you might have had. I don't know. Any questions for Amy? Yes, sir. Ben.
Just a quick question. For the pediatric, the PEC kits, have those been sent out to EMS agencies that filled out the surveys?
So the PEC kits are for PEC agencies. So if you are a PEC agency, you can have a kit. So obviously, we'd love for them to fill out their survey. But if they become a PEC agency in New York State, and you can do that right at our website, and there's more information, they can have a kit. So some of them have been distributed. There was a little bit of snafu in my mailing plan. So it is underway. They will be going, the remainder will be going out soon.
Sounds good.
Thank you. Yes,
Thanks.
that is a good point.
That's just one perspective. Director Ryan, did you have a comment? Okay. All right. Okay, any other questions for Amy Eisenhower? All right. Well, I'm looking to my left to see what Nicole O'Toole has to tell us today. Welcome, Nicole, and we look forward to your report. Always exciting. Thank you.
I'm sorry, Doc, I do have a few things. I thought.
Oh, you do?
Oh, sorry, good.
I'm just following the agenda, Chief. Oh. Nicole?
Okay. Hello, everybody. So as Amy mentioned, the survey was completed, and they had about 7,000 agencies across the United States. Better. So yes, they're going through all that data, and they're very, very happy with the percentage that they got. Also, the fans are working on FESAT, F-E-S-A-T, which stands for Family Engagement System Assessment Tool. And this is to improve family resiliency within the hospital, and that should be coming out later this year. And then they also have the HR 6960, the reauthorization was approved by the Senate, and they are going to be giving us another $2 million next year, so that's always good, and that takes us out until 2029. So a very quick report this time. There's a lot of things in the works, so I'm hoping in December I'll have a lot more for you. Thank you.
Thank you. It would be very helpful if you could potentially give us a written report with some bullet points so that it just highlights all the wonderful things that the Family Action Network is actually doing, so that we can, get the word out even more broadly than we can via these podcasts and minutes or live stream webcasts, I guess. Okay, Director Ryan, you are up.
Thank you very much. I want to start off just with one thing on what Amy reported on, which was, the survey that went out and the survey that came back. New York State would prefer to not go by percentages in this case and go by total number of agencies that responded. Because if we look at total number of agencies that responded to the survey, we have like more than most states that are out there. If we look by percentage of agencies, we are actually around the 25 percentile, which actually isn't bad for New York. So we have about 250 agencies, 200 to 300 agencies that respond each year to the survey. We're happy with that. We'd love to see more. But I think it's also important to understand when people look at things, or if you go to a website and you see the percentage and you say, you okay? When you see the percentages that, we have a lot more agencies, and so, getting all those agencies to respond, particularly this year with the survey being a little bit longer than what it has in the past and more of a commitment, it's been a challenge, but something that we continue to look at. And so thank you to all the agencies that did respond. It is extremely helpful, both for ourselves in the state as well as nationally, and having all that information in there. So wanted to just touch on that part. So thank you. And thank you to Amy and your team for everyone who made that possible. So a couple things on the Bureau side. I'll try and keep it brief this time as well, as I know many of you also participate in CMAC and SEMSCO, and there'll be a little bit longer of thing going on, report for there. But some of the big things that are going on is really just the growth. So there's a lot of new initiatives that are going on, a lot of new things, a lot of growth that's coming with it. You've seen a number of postings for different job positions and things within the Bureau. We've hired a number of positions. One of the positions that we recently hired was the Bureau Chief for Administration. And so some people said, well, I saw the Bureau Chief was hired. Are you leaving, Ryan? No, we're growing, and we're excited to be growing. Our counterparts are divisions. So the division of hospital, the hospital world is a division, and now we are transitioning over the next couple of months to a division as well, with 3 bureaus that will be underneath us. So as you've known us for many, many years to be the Bureau of EMS, that's going to start to see some transitions, some title changes, some different things that are moving. But we're very excited that we have actually hired our first Bureau Chief, which is the Bureau Chief of Administration, which is Lynn Ferrugia, which you may recognize the name. She is actually back with us. We're very excited to have her back. So she'll be leading that team. The entire team is still there. Michelle, who's been doing a wonderful job, is still there as well. This is in addition to, and then hopefully we'll be continuing to grow that administrative team as well as we grow both the other bureaus, which will be the Bureau of Surveillance Investigations and then the Bureau of Emergency Management, which will have our task force on it, to be able to better prepare for the future and to respond to things and needs that we've been doing for the past couple of years, but now will be under kind of with more assistance and more resources that are out there. In addition to that, and something particularly for this group to, and everyone watching online to be watching for, is my guess is probably by October 1st, our EMS for Children position, which has been vacant for a little bit, will be posted. And that's through Health Research Incorporated. So for many of you who know, but some of you who may not know, the grants, many of the grants for the Department of Health are run through HRI, or Health Research Incorporated. And that position is actually is an employee of that. So we will be putting out some information on it. Please share with your friends. If you know someone who might be great for the position, we would love to have them apply. Anybody is eligible to apply as long as you meet the criteria that will be in the postings. And we do have a little bit of a change in the way that the program will be running in the future. And that's, I think Dr. Cooper will be happy with this one, but putting more of a team approach on it. So we have Jacob, Amy, part of her job will be part of it. The new position will be part EMS-C and then part some other things too. But really working towards the future, having a team approach to many of these groups, so that if someone does get promoted or goes somewhere else or something else, that there's still the institutional knowledge that's there. And so that's our community outreach branch that's going to be growing into the future. You'll be hearing a lot more about that, but you'll see that in the job position as well, where it will talk about a number of different roles that we'll have, not just for EMS for Children. And, the goal there is to give EMS for Children more support, more specialized support in certain things in order to be able to advance into the future. And then the last thing that I just want to, that we've been talking about in the office for a little bit, but something that we'd love to hear the feedback from this group as well, is recognition. So we have seen an increase in our PEC programs for many different reasons, especially since the start of it just a few years ago, and we want to start to recognize some of the great work that they're doing. And so, as you know, we have our state awards that happen at the Vital Signs Conference every year. and we do have a pediatric award. But moving forward next year, we're going to look to add either a state PEC Program of the Year award or a PEC Innovation award to next year's award set in order to recognize just the great work that our PEC programs are doing, that this group is doing, that individuals are doing. And so we're excited about that one and would love to hear, the feedback, suggestions, and comments as we develop that new category or that new award to recognize the great work that's being done for the pediatric community and our pediatric patients. So just want to thank everybody here for everything that they do and for making all these things possible.
Director Ryan, thank you very much for that complete report. I would appreciate it personally if you would once again state the 3 bureaus that you've formed under your newly forming division, so everybody is absolutely clear as to what those bureaus are.
Sure. So one bureau will be responsible for administrative functions, so all our contracts, our invoices, our bills, everything that happens in that. The second bureau will be responsible for everything that really you see today. So our day-to-day surveillance, investigations, compliance, and regulatory oversight. And then the third bureau will be responsible for things that we'll see in the future that you saw come into statutory requirements a couple of years ago, which is our state EMS task force. And so those are the 3 bureaus and where things will lie.
Thank you. I think that, there's, shall we say, a growing recognition, at least nationally, which I'm aware that, and particularly in terms of emergency preparedness, that support for the logistical side is, if anything, equally, if not more important than support for the clinical side. And the fact that you're thinking about, a Bureau of Emergency Management, if I heard the words correctly, that is great news. We can have further conversations about this offline. It's, the job of the clinician is to take care of the patient, and the job of the logistician is to make sure that the clinician has all the things that he or she needs to actually do that task. We often wonder, or, who's in charge, in a disaster. The truth is, everyone's in charge of what they're in charge of. When it's all hands on deck, all hands have to be on deck. And, yes, there is always a unified incident command for any disaster under the National Incident Management System and the State Incident Management System, of course. But that support function is seldom talked about to the extent that it really should be. Anyway, more conversations to come on this, Ryan. But you have my kudos for this. Now, I also want to really publicly acknowledge the extraordinary growth in the Bureau of Emergency Medical Services and Trauma Systems, soon to be the Division of, presumably, Emergency Medical Services and Trauma Systems, or whatever the new name is going to be. I've had the honor of serving the people of New York State through these EMS committees for a number of years, as all of you know. Yes, I am a dinosaur. I try not to be, Tyrannosaurus. I'm sort of more, one of those soft, fuzzy ones. But we've never seen this kind of growth before, and, I don't know what the special sauce is, Ryan, or, whether it's your sweet personality or whatever. I don't know what it is, but you've accomplished things in terms of getting some human power behind these efforts that none of your predecessors was ever able to accomplish. So let us be extremely grateful for that, because as we all know, without the kind of staff that we need to get the job done, the stuff piles up on the desk. And you've all seen that bank ad, right? Your loan should be ready any day now, any day now. But now maybe with the new Bureau of Administration, among other things, The loan will be ready any day now. So Ryan, congratulations and thank you for what you've been able to accomplish.
Thanks. Definitely not me, definitely a team approach, and a lot of different things coming into play at the right times, and support from, the department in a lot of different angles. So it's been really nice to watch the growth, as well as also it's been a governor's initiative and been in the governor's budget, and that's really what's driven kind of the growth and the support to the EMS community that we've seen. There's just one last thing I would like to...
Someone does have to tell the governor, though, that the support is needed, so thank you.
So one last thing, extremely important. So this week on Thursday, we have our EMS Memorial, which will happen at 11 a.m. Down at the Empire Plaza. So for those of you who are available, or those of you watching online that can join us and attend with us, we'd love to have you join us. It's a very special memorial. There are 8 honorees who are going on this year, and so that will happen this Thursday at 11 a.m.
Thank you. One quick question that you did not cover. There has, as you know, been over the last year, quite a bit of interest in a position for a full-time medical director for the, for the bureau/division, whatever it is. Any update on where we are with that?
So it's part of the new structure that's coming in, the expansion, and so we'll most likely see a full-time medical director come into that position. We're just waiting for that to kind of get finalized with all this movement and the positions that are being hired.
Great. Okay. Thank you. Any questions for Director Ryan? All right. Well, hearing none, we're going to move then right into old business. It does seem old, but it's actually not that old. Sharon, I think we've been working on this for maybe just a little over a year when we actually think about how long we've been spending on the project. And I did have an opportunity to chat with Sharon briefly before the meeting, and I think she has some really exciting updates for us. So Sharon, please take it away.
Okay, so we've, as Dr. Cooper just said, we've been working on this for a little while. So do we have the presentation here? So what we have come up with so far is, of course, we've been working on trying to decide what we wanted to include in a PowerPoint presentation that could be used on the Vital Signs Academy or be taught in various locations around the state, at state conferences, things like that. And so the first goal was we decided we were going to do some videos, and so we'll talk a little bit more about that in a little bit. But the last thing that we've done, and since our last meeting, is that I kind of put together an outline of all of our discussions and kind of a beginning outline for the PowerPoint. So I just kind of would like to briefly go over this. So our objectives that we decided on were to review elements of de-escalation and how they relate to the pediatric patient, to discuss general principles of safe de-escalation, to understand how those principles apply in various situations, and this is where the videos would come in. So there would be one video on aggressive and/or paranoid children, one on suicidal patients, and one on patients with developmental issues such as autism. And then the last objective that we have been working on is to discuss the potential options when verbal de-escalation attempts fail. Now that will be the smallest part because our goal is really to work on the de-escalation for this particular PowerPoint. But then we decided that at the end of the PowerPoint, it would be good to have a discussion of, okay, what do you do if these things fail, and maybe have an open discussion with people who are in the presentations. So I'm just going to briefly, I'm not going to go through each slide or each group of slides, but the first objective was the elements of de-escalation, and we kind of plagiarized, I guess, maybe, some of the slides from FIDNY. They had a PowerPoint that they use in their training on de-escalation. So we kind of used one of the slides from there, which was elements of de-escalation, which I thought worked quite nicely here. And then we can expand on each of these points as we choose to. So there may be, multiple slides on a particular objective, but These are kind of the types of things, so respecting personal space and.
Excuse me,
setting their
one
limits.
second, Sharon. Can we ask the projectionist to maybe make that a little bit bigger so people can see the, oh, sorry. I should have leaned over. I thought it was somebody at the other end of the room.
Great. Yeah, I have a nice written one, so it's easier for me to see. So at any rate, so different points about, being concise, respecting personal space, setting clear limits, things like that. So that would be one segment of the presentation. And we'll develop the slides to explain most of that. Then we would go into the additional issues. Well, how does this affect pediatrics? How is it different in pediatrics? So thinking about children's language skills, their comprehension, emotional changes, particularly in older and adolescents, as they all go through those different stages that they go through. And then the child's perception of the situation as well as their physiological development. So we decided that we would then expand a little bit on those points. And then we would go into some of the safe de-escalation principles, and again, expanding on active listening, conflict resolution, some of the principles that are out there that we would do at least in several slides on to expand upon that. And then we're going to bring in the lovely document that was shared with us at the last meeting on how to calm agitated pediatric patients from the New York State handout there. So we would either put this here or at the end of the lecture as a summary, but again, that's an excellent document. I don't know if all of you had a chance to see the document that Amy passed out a couple of weeks ago and has been sending out to agencies. Excellent document, so basically, talks about creating a calm space. It talks about reducing agitated behavior, things that you can do to do that. It talks about calming methods. So, it was an excellent document. So we decided we would either include it in this part of the PowerPoint or at the end, depending on how everything else flows. When we got to the videos, which is the next section, where we're actually looking, okay, how do we use these things? What do they look like? In action, we have the three scenarios. So the suicide patient, and again, we came up with a couple of objectives for what we'd like to include in that video. Of course, this is subject to change. So as we do the video, if something else comes up that we think should be included, we would then, of course, include that in our objectives as well. Or if there's something that just doesn't seem to fit very well there, we can modify that. But I think as we're doing the video, we'll get a better handle on whether or not these objectives need to be changed. And then there'll be some discussion points for after the video. So for each video, we have our objectives for that video, which may be included in the video as either at the beginning of the video or as not a voiceover, but a text over, or maybe just be something for us internally as we're doing the videos. But then there'll be a discussion point for each one. So for the suicide patient, it would be that, the dispatch information may not always provide the right information. The scenario actually is one where there's an injury. And so it's not until the crew actually gets there that they find out that this is an agitated patient who injured themselves striking out at others in anger. And so again, that would be our primary point for that one. And also is looking about issues related to depression and agitation would be involved in that as well. The case two would be the patient with autism. And so again, we've got several objectives related to learning about autism and how the autistic patient would relate to in a situation, what their perceptions would be, and how they would be different from the normal child, or no, I shouldn't say normal, the average child. And so we're going to be talking about that and then indicating that family and caregivers can be extremely valuable in helping us to de-escalate a child in that situation. Also, the fact that they're visual learners, and so sometimes demonstrating what we're doing on somebody else, on a doll, in some other way, so that before we actually do a procedure to a child. And then Mark Filippi, when he was part of the group, he's now had to leave the group, unfortunately, but he did come up with some interesting slides that he had sent me that were on the common traits of children with autism, as well as other communication skills and things like that. So we'll incorporate some of that into this particular scenario. And then the last scenario is, I'm missing a page here. Oh, there it is, I'm sorry. The paranoid patient. So this would be the one that gets a bit out of control. So, so again, what can you do after? The video itself will not show the steps beyond de-escalation, beyond the verbal de-escalation. It will stop, and then at a point where we can see that what we're doing is not working, and then at that point there will be a discussion. So because it's going to be too long to be able to go into things like how do you safely restrain a child, how do you, the issues with pharmacological techniques and things like that. So we would not be putting that into the PowerPoint itself, but would be opening that for discussion as to, okay, what would you do if you got to this point? And hopefully then getting the audience to become more involved in the discussion as to what they do in their particular regions. The big thing right now is that we are waiting for the videos to be finished. And so Vidney is going to be doing that. And I'm going to turn it over to Chief Pataki here because he can tell us what the progress on that is.
Great.
Sharon, before you jump in, Sharon, I would potentially ask that the group reconsider the issue of, the paranoid aggressive adolescent patient in terms of what follows failure of de-escalation. I'm not talking about getting into great detail, but I think in terms of a suicidal patient, I think in terms of an autistic patient, those are the, I'm not going to say that they're straightforward because they're not, but, the one that I think, at least I see most commonly being problematic in our emergency department is the paranoid aggressive patient, who's bigger than me, but is 15 years old, and no one really knows what to do with that kid. It may be as simple as saying, at a certain point we say we have to treat him as an adult, right? Okay, and whatever we do for an adult, we have to do for this kid. Mm-hmm. But I do think we have to be a little bit more, directive than, simply opening it up for a discussion. We should have, I think, a bit more of a structure to how that situation is dealt with. Thank you. Chief?
Great, thanks, Doc. And first, I really want to hone in and thank Sharon for all the work that she has done. She's absolutely incredible and vital to keeping us on track in this subcommittee. So with regard to the videos that are being shot, one of the scenarios, we tried to get that done over the summer, and as most of you know, getting anything done over the summer is very difficult, so I apologize for the logistical issues that caused the delay. We were hoping to have a little tidbit of that video to show at this meeting. I'm happy to report that the next scenario is scheduled to shoot on September 27th through the 29th. There's a collaboration between the FDNY, BMCC and Megan Williams, and Northwell Health as well, who's going to give us the facilities. So we're all kind of coming together to make sure that we can provide a product. I know this is a long time coming. I'm hopeful and I'm very optimistic that this is going to be a product that everybody is going to like in the end. So with that, I'll stop there. Thank you again, Sharon.
Thank you.
Thank you, Chief. Sharon, any other thoughts about the project at the moment?
No, at this point, as I say, once we get that, then we can modify the PowerPoint in accordance and move forward. But yes, we can certainly think about how we might be able to expand that last little section.
Great, thank you. Chief, do you think it will be possible to have at least one, if not two, of the video shoots ready to show us next time?
I'm confident that we will have one. I don't want to overcommit, but I will certainly make it a goal to have more than one.
Please, let's make it more than an aspirational goal, though, right? Let's see if we can't really get it done. This has been, it's been hanging around for a while, and although, frankly, for things like this is sort of happening at breakneck speed, every day these kids are out there, and and our folks need all the help they can get. So the sooner we get this out there, the better for the kids and the better for our providers. Thank you. Dr. Von Dion.
Yeah, great work again, committee, Sharon, I know Chief as well. This is excellent work. I had a number of questions that just came up as you were talking about this. First of all, I think that the charge was actually, was indeed to talk about de-escalation primarily. That was the charge of the committee. It was not, well, now you give these medications or whatever, So I think it's important that there's not a scope creep in this group, that it's a de-escalation. That's where the focus really is. And, even though I totally concur with Dr. Cooper, but I just think we need to be careful that we don't be careful about that.
Understood.
But the other thing is that I wanted to ask about is, and I think it's probably not too early to talk about this. One is access to this module. Where will it live? How is it going to be disseminated? What is your intent with that? How many people should you reach? So the data about, or the mechanics of that, I'm not clear about, and maybe that should be thought about now as well as we're moving into the actual having the module complete. So that the average EMS provider on the outside is like, well, how do I get to this? How do I do this? And then in conjunction with that, I would say is maybe, and this is next time a little bit too, or maybe already start thinking about it, is the length of the module. If it's going to take 8 hours to do this, versus 2 seconds, I mean, there's a difference. What is a reasonable amount that you would say would encourage people to take this? Because if it's too long, and I learned this when we were doing pediatric advanced life support, when I was doing that nationally, if it's too long, people won't take it. If it's too short, it may not be seen as valuable. So I think that might be something you may want to think about as you're putting these final sort of things on it. And then the part of the access is how do you intend, or maybe we start thinking about it, is tracking its use of how many EMS providers do that. And maybe there's already a mechanism for that, and it depends a lot where it lives, of course, So anyway, I'm just bringing these things up that it's done in tandem. Rather, now you have this wonderful module, and now it goes through another year of trying to figure out where it goes, and how do you advertise it, and how do you market it, and how do you do it. So I'm just bringing those things up as an area of concern, because you can put a lot of work into it, but if it's not used, then all that work is gone for naught, and that would be a real shame with the tremendous work that you guys are doing. So anyway.
Here.
Just briefly, this was intended only to be a lecture, not a course. So it's intended to be an hour, maybe an hour and a half possibly, but not very long. But I would like to turn it over to Amy, because Amy can give you answers to some of those questions.
Yes, so how to distribute the course to providers has been included in our meetings and planning. So this would, like many things, be distributed via the Vital Signs Academy. So as you know, New York State has its own LMS, Learning Management System, for EMS providers that is free to any New York State EMS provider. And quite honestly, when I was a New Jersey State provider, I did attend many of the classes during the pandemic. We will be distributing it via Vital Signs Academy, and that will give us the ability to obviously have it be free for EMS providers, along with the other classes that are on there. We would work with education, so education has been involved in the planning. They'll review it for what CME will be awarded for it, so it would also be able to be used towards continuing education and recertification. And obviously, we would promote it through the EMS for Children program, so it would go through Always Ready for Children, the pre-hospital PEC program. We also do other outreach through the program agencies and EMS coordinators and other stakeholders around the state. So we would put it through our promotional channels.
And Amy, if I could then ask, sort of along with that, which is this is very helpful actually, is what is the goal for how many EMS providers there, or what % of EMS providers do you think we should say this is really what we're shooting for? Because that relates to the promotion. If you're finding out that it's only 1% that have done this, is that adequate, or where is your goal?
I guess just dovetailing on that, this might be a question for Ryan as well. Does this type of education and training reach the level at some point of some of the mandatory training for the state, right? Where once we've, I think, perfected the level of training, I think everyone who's in the field knows the answer is probably. But obviously that's a decision above my pay grade. But I think it might be something, again, we just start thinking about anticipating the next several years of that same level as, safe transport, right? Something that's every provider needs to be able to know. Thank you.
Sure, and it's definitely one of the things that we consider is, in the development of these and as it comes out, but also trying to make sure that we don't get ahead of ourselves in some of it and making sure the content that comes out is good, it's well received, that there's not edits or additions or changes that need to happen because of protocol change or something of that nature, or just from feedback of when those providers are able to start taking it.
Maybe one of the things, as you're looking at whether eventually it's mandatory or not mandatory, voluntary, is looking at some of the data on the frequency with which ambulances are transporting patients in this age group with autism, developmental what's now called neurodivergent patients, suicidal patients and whatnot. Because the more patients you have, I think we were talking earlier, Nicole and Sharon, like how the number of patients who fall into these categories have really increased over the last numbers of years, and that might drive you towards making this a little bit more forceful in terms of promotion and perhaps mandatory. But we know the problems with mandatory things too, so.
Dr. Foyer.
Hi, I just wanted to ask, after the kind of course education distribution on websites, has there been a discussion about on-the-fly access to this information or video?
So I think the on-the-fly more refers to protocols. And so those are opportunities for things like Muru or, other distribution pathways that are being used in some other regions to be able to, have information that's out there. I think, one of the other things that might come out of this in the training and the education is the protocol committee, both the collaborative and the unified committees may look at theirs and say, based on this education, there's some things that we didn't address in our protocol that we might want to add into it, or a supplemental factor, an appendix, or something else that goes along with it. So I think there's a lot of other opportunities that comes out when, education like this comes out, for the ability to look at it and determine are there other changes or things. I don't think this education, and please, by all means, feel free to correct me if I'm wrong, isn't something as much for, on the fly. This is the, how do we prepare you best for the situation? And then there are other tools and things that would be used for on the fly, including, and not limited to medical control, and being able to pick up a phone and call the right person at the right time. But even some of those things can change from region to region, and education like this offers the opportunity to open and foster conversations. Calling your regular medical control or speaking to your normal medical control physician may not be, the perfect, endpoint for a pediatric patient, to where there might be opportunities to connect to specifically a pediatric physician or someone with that specialty within that medical control realm. That's challenging. And, our medical control is a challenging thing in itself today. But with technology and with things changing and different opportunities, it might become something that, is more available, and, kind of where that comes from. As well as, thinking outside the box of, this is not just for emergencies. We deal with a significant number of patients that are transferred from institution to institution, and those patients are normally, known by one institution or the other, maybe the sending, maybe the receiving, and making sure that the EMS provider, while transporting that patient, can be speaking to the right person to help and aid in treatment of that patient during that transport. And so we are seeing, more and more of this situation. We see it, even in our, patients of pediatric patients boarding in ERs at times, because they're waiting to get a bed in another facility that, would best be able to suit them. And then that transport becomes that factor too. So lots of different things to come. I think step one is getting the education out, and thank you to FDNY and your leadership and everyone for allowing you and your entire team to work on this. We really appreciate it, and we're excited to see it come out. Did that answer your question?
Any other issues regarding the pediatric agitation project? Oh, sorry. Ben, go ahead. Oh, I'm sorry.
Yeah, the one,
First name, last name.
oh, Maya Dorset, on the record. The one comment I would make about mandatory education is I would be really reticent to think about making mandatory education part of a regular recertification cycle. And I think it all comes down to what are we actually trying to achieve. It's sort of the same thing. We don't have any data that says that mandatory education on pediatric transport has changed whether or not children are transported safely in New York State. And I think the better thing to say is, how do we start giving agencies, for example, quality measures to say, are we doing this right? And then giving them tools to achieve that. Education is one part of that. On a national scale, things like the National Registry are moving towards something called continued competency, which is, for example, if I have an EMS clinician who has demonstrated repeatedly that they are able to effectively de-escalate pediatric patients, right? That person does not need to do a 1-hour video on pediatric de-escalation every 2 years. They can be sort of signed off that they've completed that as a core competency. And so I think we might want to be thinking more of what are the core competencies we want people to be able to demonstrate beyond, I can put somebody in a traction splint and I can bag a mannequin every 2 years, or mandate this education and say what guidance and quality measures can we give agencies to say, are we doing this right? So that they can start examining their initial education systems and their continuing education. So like, I love education, I fear mandatory. Thanks. That's it. Thanks.
Dr. Cooper.
Thank you, Maya. Yeah.
Maya always brings up these incredible
Matt.
points. I think one of the things to consider, which everyone in the room is, well aware of, is any challenge I don't have an answer to by any means, is that even though I think Chief Patek can keep me honest, I think even in the fire department, which, sees 85,000 some odd kids a year, about 10% are behavioral health. The exposure to high-risk behavioral health patients under the age of, 18 is increasing, but when you divide it by provider, it's still very rare. So I struggle with the competency piece, because I think as you spread out those patients, well outside of New York City, but just using as an example of high volume, high exposure relative to other agencies, that's where I struggle. And I wonder how we, and a problem that the larger institutions are well aware of is how do you maintain competency for a large number of people for a low frequency event. So I think there's probably somewhere in the middle to Dr. Dorset's point. Thank you.
And I
Thank
would
you, Matt.
also, I'm sorry,
Elise,
one more
please.
thing here.
Go ahead.
I would also add to that, that this is not unique to the EMS world. This struggle with how to manage these very complicated, developmentally neurodivergent kids, including suicidal issues, is inpatient ICU. I mean, it's everywhere. We have special teams now inside the hospital trying to deal with these behavioral things that everyone is struggling with, lest you think that it's very complicated. And I think anything that we can do will be a positive, no matter how we do it, because of such a huge problem that we're seeing in pediatrics.
And to Dr. Cooper's prior point at the beginning of the meeting, I think while we tend to have very emergency medical services-centric conversations, this group represents the spectrum of providers who take care of kids in all settings. So this training will be, I think, again, coming from my bias as an EMS provider, but I think looking more ubiquitously at the goal and mission of this group. That's why this type of work is so critical.
Thank you. A very rich discussion, and, a lot more work to come. Ben, please.
Yeah, sorry, I just had one more thing to say. Because I know it's always mentioned to incorporate caregivers, parents, people that are familiar with that particular child, whether it's a developmental or behavioral issue. And I think that it really, or at least my personal opinion based on previous experience, to really emphasize that point, because sometimes as providers, we're not necessarily great in getting outside help, but for these particular children especially, whether it be a school teacher and you're, an EMS provider going to a call there, or whether it's a family member, everybody has their quirks, everybody has their ways of de-escalating within the household, and I think that should really be a point of emphasis with the education to incorporate those resources that are most familiar with the child.
Certainly a fundamental precept of all children with special health care needs, protocols, whether we're speaking medical or behavioral, involve the parent who knows the child the best, or school teacher, as you say, or daycare provider, whomever it might be.
Dr.
That's
Cooper.
really good advice. Matt?
Forgive me,
It's fine, go ahead.
more comments today than I typically do.
No, it's all good,
Can
all
I just
good.
ask the group, and I guess Sharon in particular, I think one of the challenges, which I also think is not unique to the clinical environments which I practice, is the integration with our law enforcement colleagues at the scene of many of these patients. And certainly down in the primary where I practice, it's not uncommon for patients, sort of regardless of age, to be in handcuffs as sort of a quote-unquote policy of the local law enforcement. I do wonder, as advocates for children here, if part of our training, part of our advocacy, recognizing that we are not, certainly not a law enforcement officer by any means, but how do we continue to advocate for perhaps within this training a more judicious use of that type of restraint? Or how do we bring those people to the table, if they're not already, to be part of the conversation, both for this education and in this programmatic effort moving forward?
An excellent point. I think this is something we're going to have to ask the work group to think about a little bit. As we finalize getting the PowerPoint together and the videos and so on. Yeah, that can be a problem, and something we should really be cognizant of as we put these scenarios together, particularly the third scenario involving the aggressive / paranoid, violent, whatever, adolescent male. Okay. Very good. So I really want to thank everybody for an incredibly rich discussion on this, and I'm sure Sharon's, going, oh my God, now what? But if there's anybody we know who when the words, oh my God, now what, come to the fore, Sharon's the one who can handle it. So we know that to be the case. So thank you, Sharon and Chief.
There is one thing, though, is related to that, and that is Nicole and I were just having a very brief conversation here about how the agencies themselves, once they get this as a tool, and they can do their own in-services, and there's no reason why they can't reach out to the the
course.
officers in their region. So I think there's potential that this could be utilized to build some of those bonds.
Absolutely. There's no reason this couldn't be shared beyond the EMS world. Exactly. All right. So I think next up we have Dr. Vandriat to give us a little update on the procedural sedation work group.
Yes, thanks very much, Dr. Cooper. And I appreciate Chief Pataki's notation of the summer, okay, because we had a similar issue. It's hard to get people together with all the busyness. Just so to remind the committee about what this particular project is about, you may remember that I think a couple meetings ago, I had put together a bit of a presentation how the Society for Pediatric Sedation is very interested in making sure that adequate sedation management of uncomfortable, painful procedures everywhere along the line is done. The Society for Pediatric Sedation, that is their area. They're the nationally recognized society for that, for making sure kids are comfortable during usually invasive procedures. And then the EMS-C, the pediatric readiness surveys, for example, if you look at the survey, it actually looks at what happens in the ED. This happens in the ED, but, and it actually discusses things like medications, for painful procedures, the kinds of procedures that are done that could be really uncomfortable. So I had presented that merging these two national organizations and their goals, to make sure that this is done, should we be looking at this for New York State in emergency departments. So again, I'm just refreshing people's memory here a little bit. We then agreed that we would put a small working group together to begin to wrestle with those concepts at least. That group has met once. We met at the very last day, I think, of May. Dr. Kaleo, Dr. Foyer, Dr. Harris, Nicole O'Toole, myself, I may have missed someone. And we had a good discussion, recognizing that this is a pretty big project. We recognized that we didn't have all the right people on the group. For example, we clearly needed to have an emergency department nurse on there. And so we're reaching out to the Emergency Nurses Association to see if we can get someone, or if you know someone in your particular area who has it. Nicole particularly had reached out to them, and we're still waiting to hear back, but I think often locally it's probably a little bit easier to get someone you know, right? We also recognized that we needed more input on what might have been done or what is being done around the country. And so again, Nicole had reached out to the Family Advocacy Network to see whether or not anybody was looking at some of these kinds of things, that if a patient has, let's say, they need a scan of some sort in the ED and the kid's really anxious or maybe autistic or has difficulty with tolerating those, what do people do? I know in our own area, community hospitals, small hospitals, they don't have as many resources. It could be brute force, just pushing the kid, having the kid holding it with 5 people and doing whatever they have to do. That is not optimal for pediatric patients, and it can be very traumatic, especially with the neurodivergent population. So anyway, we are in the process now of expanding that group a bit. We are also trying to figure out, and any suggestions would be helpful, is can we get some data from any institution, whether you're in a big medical center or whether you're in a smaller community hospital. How do we find out what some of these issues are? I can tell you that in our own medical center, and we're a children's hospital, we're actually, I think, the largest children's hospital in upstate New York. Yeah, we are, all the services that we have. So we, however, still get reports from families who come to our own ED and they have a very traumatic experience. And we're presumably cutting edge, but we still have difficulties. So if there is data that we somehow can access, what actually is happening. Sometimes this can be looked at by looking at pharmacy data, what's being done there. Sometimes it can be observing, and doing that. Anyway, we need some of that data. We will be putting more meetings together, trying to wrestle with this. We thought it might be best even to, you start off with a few hospitals in an area. So that Dr. Kaleo's in the Syracuse area in central New York, where I'm in central Midwestern sort of New York. York. There are other areas, Dr. Harris is downstate. So could we take, a hospital or two, particularly community hospitals, and see whether we can get some data? Can we implement some strategies for that? So many things to do, Dr. Cooper, but I'm hoping that we can keep moving this forward. It is a very big issue. One nice thing is that Wednesday I'm leaving for the Society of Pediatric Sedation meeting in Boston, and that'll be a 4-day meeting, and I will be touching base with our Quality Improvement Committee, which is where this first came up. And I had said that I would, because I'm on this committee, that I would hopefully try to network with that group and get some suggestions. So that's my report, Dr. Cooper.
Thank you, Dr. Von Diat. I'm just going to mention that Elise and I had a very short sidebar conversation just a few minutes ago about the course that has been developed by the Society for Pediatric Sedation. I have not taken that course, but plan to, and I reviewed the material for it, and it looks like it's really outstanding, and I would hope that anything that we came up with in terms of, guidance, whether it ends up as protocol or an educational session or whatever, mirrors the national, guidelines that the Society for Pediatric Sedation has put forward. Of course, as always, part of which is Dr. Von Diat's work. So he's very modest, as we all know, but he does a lot. So this is really exciting. The one caveat with all of this, again, we need to remember that at least in terms of the EMS world, we want to keep it as simple as possible. Simple is good. It's we don't want to overburden our medics with 5,000 new medications and so on, and all the pharmacology that goes along with it. Not that our medics are the only focus, but as we all come to understand as we grow in our in our practices, and that keeping it simple is often and keeping it to the essence is often the best approach.
Just to be very clear about this, the focus here is actually pediatric emergency departments because they have the resources. I mean, it's very different than being out in the field with, 2 basic EMTs or a basic EMT and a paramedic. I mean, that's a very different situation. Here we're talking about the kid who needs an IV inserted, and they take 5 people to hold the kid down, and they miss 5 times. And none of it is done in a way that is appropriate for the patient. There is no 4% lidocaine on the patient. There is no. There's a number of different ways of numbing skin and things like that. There can be intranasal medications given. There's a number of ways that we can handle that. I think the feeling at the Society of Pediatric Sedation and looking at the EMS-C pediatric readiness surveys is that this is an area where we don't do a particularly good job in many areas, particularly in smaller hospitals where they do not have resources. They do not have child life specialists. They have to do what they have to do. And that's how it's been done for decades and decades and decades, but there are much better ways to do it currently. And so we're looking at that, not EMS so much providers. Yes, go ahead, Ben.
Yeah. In the hospital that we work at, and I know it kind of goes and it coincides with what you're speaking about, but one thing that they're trialing right now, the residents in the ED are actually, if they're doing like sutures, they'll put VR goggles on as a distraction technique. So that's like one thing I know that it kind of coincides with that, so it's not as barbaric to like hold a kiddo down and yeah.
I'm glad you mentioned that, Ben. It's a whole big area of how to manage invasive procedures especially, or procedures that are anxiety-provoking because a child has to be still. Virtual reality is certainly one of them. Child life specialists, distraction, there's hypnosis. There's all kinds of possibilities depending on the resources. But smaller community hospitals typically don't have many of those kinds of tools. And so the question is even, What tools do they have? How do they do this? There is no data on this, to my knowledge. And the more data we can get, then that can direct us a bit for very simple things even that might be useful. But thank you for sharing that. That's good.
Yeah, and it's probably difficult to find data or accurate depiction of what actually takes place because they're not going to be like, oh, we had to hold somebody down and, they're kind of leave that out of the written record.
And they do, I work in sedation, 50% of my time, you see patients, okay? Family comes in, you look at the chart, and the chart says, everything was done great, patient did great, everything is fine, and then you talk with the parents, and they have a very different story, so.
Okay. Thank you, Elise, for an update on this very important subject, and we'll look to hear more about this as we go forward, hopefully at our next meeting. There's one item of old business that I'd hoped would be on the agenda, but is not. That's our report from our colleagues who have been setting up the crisis stabilization centers. Amy informs me that they unfortunately were unavailable for this particular meeting. So we'll try to make sure that we have a spot for them, at our next meeting. So that brings us into the new business. The first item under new business is review of minimum pediatric care standards for New York State hospitals, emergency departments, and intensive care units. Now, this item was prompted by a note that we got from Dr. Conway, who sadly is not with us today due to a medical issue that needed to be resolved. A document was sent out with all your packets to this end. In brief, Dr. Conway is concerned that there's a provision in the regulations that allows for so-called special care units, it's not clear what those are. And I think Dr. Conway is rightly concerned that patients that belong in PICUs might not be getting PICU level care if they're in one of these, special care units. So he's not with us to make the case today. So we're going to defer further discussion, action on this to our next meeting. But in the interim, okay, I think it's probably appropriate that we consider, this important issue in context. The context being, there's a document called Review of, called Minimum Pediatric Care Standards for New York State Hospitals, Emergency Departments, and Intensive Care Units that, as we all remember, was largely spearheaded by our late and dearly regarded and missed colleague, Dr. Bob Cantor. That document was put together now almost 10 years ago. Hard to believe it was that long ago, but, so the COVID time warp, I think, has, affected everyone's, sense of time. So what made sense to Amy and I in brief discussion, since Dr. Conway is not with us today, is to form a small working group that could begin to look at these minimum standards to see if there are issues that might need to be addressed in addition to the points that Dr. Conway has raised. Certainly, Dr. Conway will have a prominent role in this particular discussion. In fact, Dr. Conway, if you are online, you are hereby appointed to lead that group. But there are anyone else who wants to participate in that group, please let Amy know. I'm sure Dr. Van der Yet will want to participate in that. I certainly will. There may be others who would like to participate. I see Dr. Foyer nodding her head. I knew she would do that. And I don't see Dr. Harris nodding his. He did. Okay, so Dr. Harris also wants to participate. So, oh yes, and Marilyn Kasika is raising her hand as well from the Health Department. So there we are. This is not by any means exclusive. Anyone else who has, did I miss someone? Pardon me? No, I have a question. Yeah. So anyway, that's going to be our game plan. Amy is going to, set up a few conference calls for us in between now and our November meeting. November, right? November. So it's November, not December this year, guys. It's November, our pre-winter meeting. So more to come. It was a pretty good document. We all recognize that it wasn't perfect, but nothing ever is. It's always a work in evolution, and but it is a good time for us to, think about. Excuse me. It is time for us to take another look at that document and see if there are issues that need to be addressed. So, any questions about that? Yes, Pam.
Pamela Foyer. One comment for committee, since I don't want to speak for someone that we've not met or isn't at our meeting, but we now have a pediatric critical care nurse on the team.
Sure.
And that may be very helpful from a nursing
Absolutely.
Nursing expertise and nursing staffing levels. But there's another document, an article that's come out in 2019 from Pediatric Critical Care Medicine, in which Dr. Conway is the final author of the voting group, Criteria for Critical Care Infants and Children, PICU Admission, Discharge, and Triage Practice Statement, and Levels of Care Guidance. And I think that article might be helpful to send and for the committee to use in comparing the two documents, because that's more up-to-date information.
Very good.
Yeah, Dr. Conway had provided me with some documents for, our work group, but when we chatted about it, I had noted that this hadn't been updated since 2015, and he was like, oh, we probably should take a look at that. So I think that was the gist of discussing some of his concerns, as Dr. Cooper summarized. But yes, there are other documents to use. I do understand that there has been some other work around New York State around pediatric standards, not just for obviously critical care and things like that, but Office of Health Emergency Preparedness has been doing some work with EMS-C around ensuring that children are part of those emergency disaster plans in a variety of levels. So I will reach out to our partners there, Kate Butler as a party, and Deanna Radigan, I'm not sure if she's here, but we'll reach out to them and include other stakeholders that obviously I was not here when this document was created, but that have grown, and maybe we could even include someone from the Pediatric Pandemic Network that was just kind of convened through EMS-C and see if there's a New York representative kind of involved in that work. Because now, as we know, pandemics are a part of a lot of our work.
And in no way did I think that article should take place of us reviewing or updating, but be a source, a reference.
No, I obviously that's understood, Dr. Foyer. But there are other documents out there, and I know that Dr. Conway knows every one of them. Yeah. Okay, very good. All right, so more to come on that one next time. Now, Amy made me aware of one other potential item of new business. Amy, perhaps you could, elucidate us on what this involves. does seem as though recently there was a child with special health care needs who protocols seemed to prevent being transported to a facility that was regularly caring for that child. And as we know, kids with special health care needs often do best in the facilities that know them best, not to mention parents who know them best, but also facilities that know them best. And so, Amy, do you want to let us know a little bit about that? And maybe we should take it upon ourselves to think about that issue a little bit.
Sure. So a parent of a child who received EMS services had reached out, not as complaining, more of advocacy and questions, right? She wanted to better understand the EMS system, how our protocols worked, and kind of what's included, but asked that our group consider looking at the protocols that we do have for children with special health care needs, medically fragile children, et cetera, and just kind of review what that policy is, what that procedure is, to have consideration for maybe, calling a supervisor, calling medical control for permission to transport, not in emergent situations, right? Like where, time is of the essence, but if they do need transfer and their hospital is not that much further, like, can we review that process? So I do know that obviously would include the protocols committee, but I do know that we can make recommendations to them on our review of different specialty topics. So it was asked that we bring that up for conversation.
Maybe just a quick
Thoughts, Matt?
I mean, there's always medical control discretion that has to be then coupled, I think, with the needs of sort of the primary area of response, right? So in New York City, where we have more ambulances than we know what to do with, it's easy for us to say, you know what, your child is cared for at this, and the child seems stable enough for transfer. I think it's appropriate for you to go on. So it's like the bane of our existence as EMS medical director is, okay, you can violate the 10-minute rule, so you can take the child to their medical care home. I think it'd be more of a challenge to figure out the type of guidance that we can provide for providers like in this neck of the woods or up where at least practices, because I think that you might be taking the only paramedic out for quite some time. But I do think that type of discretion is absolutely important and warranted. And I don't know if it's the same parent, but we've had similar conversations with another parent recently in our neck of the woods, medically fragile child, looking for protocol opportunities for deviations and changes. So I do think it's something worth considering that has to include both like the clinically relevant information and then I think probably some operational components as well.
I think the other component to this one too is it is interesting because this is actually, when we talk about it, this particular incident is from New York City. I had the opportunity to talk to the agency as well. And here's an area that is ambulance rich, but yet, the challenge is still there, right? So sometimes ambulance rich means very structured in how certain things happen. And, working through some of that, and I think we talked about, Dr. Tricette talked about what's a quality measure? What's things that look at this? Where's the abnormality is what makes people comfortable with it. In some cases, it's even as simple as, it's advanced life support or basic life support. The advanced life support provider, I think if we were to look back, probably is more often apt to turn and say, I'm going to call medical control, where the BLS provider is more apt to, we see more often where they're like, nope, this is the protocol, this is where I need to be. And so, where does that come into play, or how do we look at things in the future, for education or things like that, where even if we are in a very structured system or a very remote system, I mean, we're looking now, the Rural Ambulance Task Force group, who's been working for, a while now, and the paper hopefully will be coming out shortly, they look at it from that point of view as well. Where's medical control? What's our options? When can we deviate from something? And, often you hear, what happens in a protocol, and then also what's a guideline to that? So where's the point where you do pick up the phone because it is the right time to make the phone call or something else? And so it's challenging. I think it's an opportunity to look at. And I also think it's an opportunity internally for, agencies to have that conversation, to talk about, well, what happens, whether it be a pediatric or a geriatric, because we run into, similar issues as we get into geriatric population. I know not this committee, but similar in nature to where, they have ongoing care at a particular institution. And, where's the best or most appropriate, place to take them based on similar things.
Yeah, just a point of retort that I think what you're hinting at, which is I think on the ball, is that care is becoming more regionalized in general, and it's probably time that even though our EMS systems cross counties and cross jurisdictions, that we have to be considerate of the fact that especially specialized patients, regardless of where they are in the sort of cradle to grave spectrum, those centers are becoming more niche, and it's medically appropriate to do so. I fully support that.
Could I just ask, this is my ignorance, I think, is what is the New York State requirement, for an ambulance if they pick up, let's say, not an emergent patient, but a patient who needs to come to the ED? Because I can tell you in Rochester, these patients that are complex, they will bypass another hospital to come to our children's hospital.
Sure.
And even though they're 30 minutes away. So I'm a little confused about what the requirement is because we are already doing some of this.
I think it's more a guideline than it is a requirement. Like, you're not going to go in and see a specific regulation or statute that's very specific on it. Often you hear the closest, most appropriate. And the closest, most appropriate for your given patient may not be the closest institution or hospital that, is near to you. Where I continue to ride an ambulance, our pediatric facility is, significantly further than the closest hospital that's there, but it is, on a, fairly regular occasion, the most appropriate place for us to transfer to, because of maybe the injury, the ongoing care, fill in the blank what might be there. And, I think as you travel around the state, that changes a little bit on what's the closest, most appropriate, how far the distance is, where they're going to, and also their pathway to get there. So, as you go into the North Country, you may have the closest hospital could be 20 or 30 minutes away, but often they're, calling for a helicopter or another means of, transportation to get them to a different institution. And so, I think a lot of it is geographical as well. We see, air medical being used in a regular occurrence, particularly, I'd probably say, I haven't looked at the numbers, but probably on the pediatric patients, probably quicker than other things by nature of trying to get them to the specialized care that they need, because it's not offered in every institution. And, kind of how do we get there? But no, to answer your question easily, there's not one specific standard across the board. This is where it is everywhere. And in many cases, that might not work perfectly. If you're in the middle of Lake Placid versus New York City.
Right. So is it, again, this is a point, is my ignorance, I guess. So is it up to each ambulance corps or ambulance unit to determine where that patient will go? There's nothing in state regs which says, besides most appropriate, there's nothing, that's a lot of flexibility, because that can be up to the family then.
So I don't think it would drive down, fully down to the, say, specifically the family level or something of that nature, because the most appropriate to a family member may be different than the most appropriate to the provider who's providing that care. And that's the part where the protocols and the guidelines and transport determinations are outlined, in the guideline, in the collaborative and in the unified protocols, as well as that's also the point to where medical control gets involved. And sometimes that medical control is even used in, a non-traditional manner, where the provider will get on scene, the family says, this is the only place I want to go, and the provider, maybe the provider isn't even comfortable going that far. And so they get on the phone with medical control and ask medical control, can you talk to this family member? I see a shake of head going, and maybe Chief Pataki can actually comment after. to hope that maybe if they talk to someone else, not directly there on scene, that they talk to a physician to understand why we're taking a patient to something that's different than where they necessarily want to go, that they have a better understanding of it.
Providers often get this when they walk in. There's a particular institution that the family members want the patient to go to, and medical control plays a big role in that. Obviously you have different levels of expertise and people who can de-escalate with the family, talk to them, explain why this might be the closest, most appropriate facility to transport to. But in the end, if that is still not satisfactory to the patient or the patient's family, then medical control is vital to make that determination of whether or not we can transport to a further facility as opposed to the closest, what we determine to be closest, most appropriate.
We're, as Director Greenberg pointed out a few minutes ago, although not in these words, while our advanced life support colleagues are comfortable with calling medical control for assistance, guidance, / whatever, our BLS colleagues, much less so, and they're typically following a fundamental, line in the protocol, right? Not to mention the fact that, the great majority of basic units don't really have ready access to, a medical director, medical control that they could, reach on the fly, to say, where should I, or should I not take the kid to this hospital, but go to a different one? So I think this is an issue that does deserve some discussion, a little further discussion. And I'm going to suggest that, that following Dr. Pamela Foyer's suggestion, that we kind of wrap this into the discussion about the minimum standards for, emergency departments, critical care units, and so on, not to come up with a protocol or a reg or anything along those lines, but some, general guidance as to, where kids that have very special needs should be taken if such services are available. Typically, those are going to be available in hospitals that have critical care units, but not always. So I think it is part of that general discussion as to the role of critical care in our system and what we in New York State think is a minimum standard for critical care. So I think that's probably the best way to keep this discussion going for the moment. And we'll just add that to the agenda. Ben?
Just one thing is kind of approach that situation, because every area in New York State's vastly different. They have different obstacles. So and I think the collaboratives do a fairly good job of just not painting themselves into a corner and making it so closest, most appropriate facility, and when in doubt, or whenever there's maybe a discrepancy between what the family's wishes are and what you as the provider's wishes are, that's where you can get medical control involved. And I know that the local, the RE/MACs, they know, and they have the ambulance providers, the companies, all that sit on their different RE/MACs, and they can kind of further articulate exactly what works best for that particular one, because it's hard to, as a state, because New York City is very different from upstate. So that's just one thing that to take into consideration, perhaps.
Of course. I think that both you and Matt Harris, before he had to step away, made that point, that we're doing so much more on a regional level now appropriately because the regions themselves really have the best sense of what resources are available, in their particular regions. What I'm suggesting is that, some general guidance, it's as simple as saying, the right care for the right kid at the right place at the right time, and just say if sometimes that may require, a little more flexibility in terms of, the application of protocols, then maybe that's something that ought to be considered. So that's all. I mean, just something that sort of, gives a little bit of flexibility to the system to, allow in a special set of circumstances, a kid who needs service X that is not available at the, at whatever we might call the closest appropriate facility. What can we do about that? That's all. Nothing fancy. Okay, but just some general guidance along those lines, I think. And I just think that since that group is already meeting and considering some of those issues, particularly regard to the 2019 pediatric critical care medicine paper that Dr. Foyer cited, that that's probably the simplest way to handle it at this point. All right, so we'll add that to Dr. Conway's long list of things to consider. Ed, I hope you're listening. And that's that. Okay, I think that there may be one item of new business from Director Greenberg.
Yep, so kind of new business. I guess it's a new business. We are excited, and it will be, so for starters, for those of you who aren't aware, we have two sets of awards that happen at Vital Signs each year. That is the statewide EMS Council Awards, and that's your ALS provider year, your BLS provider year, agency year, as well as our innovation awards. And so we are excited to announce this year's recipients. I'm going to do my best on some of these names, so I do apologize ahead of time. I did not get some of the names phonetically put out there yet, but so congratulations to all the winners and all the nominees. So each region for the state awards, for SEMSCO awards, has the opportunity to send in their nominee for each region, and then the state council selects from those regional nominees that are sent in. So for ALS Provider of the Year, paramedic Nathan Peters. BLS Provider of the Year, Kyle Maxwell. EMS Communication Specialist of the Year, Charles Vital. EMS Educator of the Year, Amy Nispanzowski. I apologize, Amy. Who knows how to say that correctly?
I think it's Nita Ponsky.
Nita Ponsky, thank you. EMS Agency of the Year, Northwell Health Center for EMS. The Harriet Weber Leadership Award, Mark Philippi. The Registered Professional Nurse of Excellence, James Moore. The EMS Physician of Excellence, Dr. Maya Dorset, sitting right behind me. Who, by the way, also just received the National NAEMT EMS Medical Director of the Year Award. So one not related to the other. They're totally separate. So congratulations. The Excellence in EMS Quality and Safety, Michael Prezino. And the Youth EMS Provider of the Year, Shalom Hammerstam, sorry. And then for our Innovation Awards started a couple of years ago. These are, we work with the department to have all the regions put in different innovation awards for different categories. This is really an opportunity to spotlight some of the great stuff that's happening in an innovative way around the state, and it's something that is captured sometimes in the awards above, but not always. And so we have 4 categories for that one. This year, the Clinical Delivery Innovation Award was given to Harpers Ferry Volunteer Ambulance Service, which is the Binghamton University student-run collegiate EMS. The Educational Innovation was given to Mentor Ambulance and Scott Clark for some innovative CME delivery that he's doing. The Organizational Innovation was given to Varna Volunteer Fire Company. And the Recruitment and Retention Innovation Award was given to the Southern Tier Healthcare System, who is also the program agency for that region. So just wanted to say congratulations to all the award winners, and their awards will be presented on either Saturday morning or Sunday morning of the Vital Signs Conference in Rochester this year.
I just wanted to mention that there's potentially one other award that is not given every year. It's given to a very, very special individual who has made major contributions over a lifetime to the emergency care of children. This is my bad. I apologize for this. We should have, called a committee meeting a little bit earlier than this meeting. However, we did a little bit of tap dancing, okay, and I'm pleased to state that a small committee has chosen to make a recommendation for the Robert K. Cantor Award, for excellence in emergency medical services for children. And, the individual who has been nominated for that award is sitting to my left. His name is Elise van der Yacht. I see a stunned look on his face. Now, it's not without, notice that this year's Vital Signs Conference is in Rochester, where Dr. van der Yacht practices. And we hope he likes chicken, but it is late in the year, and that's my bad. It's my understanding that the orders for the awards may already have gone out. So Director Ryan advises me that if it is not humanly possible to get something made up for this year at this late hour, even though it is more than a month away, that it will happen next year. So I want to ask if the committee endorses the work of that small subcommittee to recognize our colleague, Dr. Elise van der Yacht, as this year's recipient of the Robert K. Cantor Award for Excellence in Emergency Medical Services for Children. Yes? That's what I'm doing. Yeah. Can I have a motion from the Pamela? Thank you. Second?
I'll second.
Numerous seconds. Everybody is seconding. I will make note of that. All in favor, please say aye. Aye. Opposed? Okay. Well, it's unanimous. Congratulations.
Well, this is pretty embarrassing. I'm not that kind of a person. I'm breaking out into a cold sweat, okay? Because it's this kind of an honor is pretty amazing. Because Dr. Cantor was an absolutely wonderful role model, and I'm just very humbled. So thank you.
Bob would be proud. Bob was my medical school classmate, by the way, but he would be incredibly proud to know that Elise was the recipient of the award in his honor. So, knowing that Ryan Greenberg works magic on a daily basis, I'm
more concerned that you think a month is a lot of time. Try telling that to Amy.
We're going to do our very best, okay? All right? Okay. I have no other items of new business to report, although I will suggest for the moment that when Dr. Maya Dorsett is formally vetted, she did say something about quality metrics. Did you hear her say that? So now that she has won 2 awards for her work in quality metrics, I think it's time that we potentially consider looking at some of those quality metrics in a little bit greater detail than we have in the past. And I know Dr. Dorsett is, anxiously awaiting this opportunity. And when she's formally vetted, we'll make that formal request for her to take that task on. So that concludes new business. Unless anyone else has any items of new business of which I am unaware. Okay, well, hearing none. Let's move on to updates from our sister advisory committees, partners and so on. It's my understanding that we have nothing from the quality and patient safety and sepsis group. So we'll ask for a report from them next time. And from PCARN with Peter Dion and Brian Clemency, I don't know if they're not here, and I don't believe they have no report. So Susan and Chris from BOHIP, are you with us today?
They are, excellent.
Wonderful, so please.
Okay, good afternoon. So just updates as far as our pedestrian safety. We conducted 3 focus groups in Albany, Rochester, and Yonkers to learn more about what community members believe were barriers to vulnerable road user safety. Under our child passenger safety, so our child passenger safety pictorial video, we're producing a video to illustrate car seat installation instructions for limited English speaking and reading populations. We just had our video shoot last week, so hopefully that should be done and up for approval. Under our counterfeit car seat publication, we collaborated with subject matter and experts and developed a publication on the dangers of using and purchasing counterfeit car seats, and we are in the final approval processes there. We also are having our webpage will be created, and that will be on the state website. Under our Safe Travels for All Children, which we also call STAC, we held one June 19th and the 20th at the Helen Hayes Hospital in Rockland County. We had 15 attendees, which is a full list of attendees. There will be another training in November in Schenectady. And we attended National Day Out in Yonkers, Rochester Red Wings game, and distributed our safety education. Under motorcycle safety, so under the Ride, Drive, Care motorcycle safety campaign targeting riders and drivers, we are producing a second public service announcement focusing on speed as a contributing factor. A speed publication, which will focus on speed reduction for both riders and drivers. We continue to emphasize the availability of basic rider training courses to riders. We collaborated with Columbia University, GTSC, and MSF to join the Seneca Tribal Nation at their two community fairs. We conducted motorcycle helmet fittings and shared our safety publications. We attended the Americade Motorcycle Rally and provided motorcycle safety materials there also. Under mobility safety, we are collaborating with the Bureau of EMS and Trauma Systems to develop a micro-mobility tip card focusing on e-bikes and e-scooters. And finally, under our younger driver safety, Driver Education Research and Innovation Center, which we call DEREC, we had 2 workshops which were conducted for driver education instructors held in Albany in July and August in Long Island. Training was conducted by the members of the New York State Driver Safety Education Association. That's it.
Wow. That's a lot. Thank you.
And we are also updating many of our injury prevention web pages on the state website.
Great. Any questions? All right.
I did.
Amy?
Do you want to share about the event going on now and the Safe Streets for All panel?
That one I'm not familiar with, I apologize.
Okay.
You might have something that I do not.
Yes, so right now, actually, in Binghamton, today and then the next 2 days, I know that BOHIP and Governor's Office of Traffic Safety is participating in
Walk, bike, the
Walk,
symposium.
Bike,
Yeah.
Roll. Yes,
Right,
so I
yes.
knew I was going to get it wrong.
Yes, I know a little bit.
So Walk, Bike, Roll, and I believe they have it every other year. This year it's in Binghamton. So tomorrow there will be a panel related to the Safe Streets for All grant program. So for EMS agencies, If you don't know, the federal government is trying to give away this money. There is millions and millions of dollars. So if you are looking for grant money, EMS is included in this grant program related to post-crash care. I believe Colony EMS, and there was another awardee in New York State, have been awarded some of the grants, but they are every year trying to award this grant money, obviously to have safe streets for all. So it is a community endeavor. You will have to work with other stakeholders in your communities. However, EMS has been notably included for our work in post-crash care. And so one of our representatives, Mike Linehan, will be on a panel tomorrow afternoon with a group of stakeholders talking about some of this work and the work that EMS does in this arena.
And I do know that Jen Hogan, our section chief, she is scheduled to go. If not, we will have somebody there in her place. Yeah. Thank you, Amy.
Thank you. Questions for BOHIP? Okay. We are, of course, honored to have with us the Director of the Division of Family Health, Marilyn Kasika. Marilyn has been quietly laboring away for years, bringing the health concerns of children and families to the fore. And I know that she has an interest in really providing us with a really full, report in terms of all the activities that her division is involved in, which we'll schedule for next time. But for today, I know she has some issues that she wants to bring to our attention. Marilyn.
I just wanted to give you an update on two things. We are in the process of developing our maternal child health services block grant for the next 5-year cycle. So we're doing a whole needs assessment to set priorities, as well as getting community input and input from providers, et cetera. So if anyone from this group, or if you have groups that would want to have input, just let me know, and then we can schedule that. The other piece that, talking about the children and youth with special health care needs and transport, et cetera, I participated last year on a rare disease work group that was mandated in law to be established, and part of their work was to make recommendations to the governor about how to handle individuals and what the state should be doing to support them. And I know one of their subgroups was emergency care, and they were very passionate about it. So if you need somebody with that kind of expertise when you're talking about your issues, just to give you that sort of flavor, let me know and I can connect you. And that's it. Thanks.
Thank you so much, Marilyn. Appreciate it. Marilyn is one of those people that, keeps quiet while she's doing, but she's a force, trust me. Okay. I am sadly informed that we have no one here from the Health Emergency Preparedness Central Office. Oh, you are? Oh, wonderful. Oh, great. Thank you. Rescued at the last minute.
All right, good afternoon, good morning. I am Deanna Radigan. I'm sitting in for Kate Butler as a party who is on a much-deserved vacation. Quick update for us, the updated hospital preparedness program notice of funding for the 2024-2028 was released in the end of May. No additional focus areas related to pediatric preparedness are in the current guidance. So just wanted to share that update. The contract hospitals outside of New York City are closing out their documentation for the previous budget period, which was ended on June 30th. There was a few remaining of the pediatric readiness assessments that we've sent to Amy. If there's any additional, Kate will forward those on to you. Facilities without a 24/7 emergency department did not complete the assessment as the system precluded them from completing it. But a handful of facilities that did not complete the activity did forfeit the reimbursement, but we had a good amount that did complete it. So And then also, we are conducting a review and update of the New York State DOH Pediatric and Obstetric Emergency Preparedness Toolkit. So we want to thank everyone that's on this committee that may be sitting on those work groups and part of those efforts. So that is ongoing, and we will have updates on that as we work through it. And that's it.
Yeah, I know Dr. Kasika has been involved with that project for many years. Right, so, it's good to know that we're all continuing to work together and to make sure that that document is, is in tip-top shape, so thank you. Amy?
So I did want to comment on the HPP program and working with our colleagues at OHIP. So thank you so much for including us. I know that this year we didn't make it in, but hopefully next year we can continue our work together. I do want to say that the hospitals that did complete the pediatric preparedness assessment that you can find at pedsready.org if you're part of a hospital, which is also a component of several other programs. So to be ACS verified as a pediatric center, you have to complete this this assessment, and also to join the Always Ready for Children program, you have to complete the assessment. So that pediatric readiness is now flowing through several different areas. But I do want to say that the last count, and I've gotten more surveys since, I believe last count that I had was 108. So I want to say we had about 120 hospitals as a part of that HPP program complete their assessment and get their scores back so that they can assess their current pediatric preparedness and move forward. So thank you so much for working with us on that.
Questions for Dana? Dana, correct? Deanna, thank you. Questions for Deanna? Hearing none, okay. I don't believe we have anybody from the regional health preparedness group with us today. Mike McAvoy, who normally has an incredibly long list of issues to bring forward to us, today does not. He's not with us today. He's traveling, and but he did say that there's nothing that he wished to share with respect to pediatric issues prior to the meeting. So we have that from him, and the STAC has not met. In a while. It's not meeting until the end of October. So I don't have a lot from STAC, but Kim Wallenstein and, oh boy, I'm blocking on the gentleman's name from Northwell. Yes, Derek Wakeman are very busy on a number of projects, and so I'm sure that they'll have more for us by the time of our November meeting. So, incredibly, I thought this agenda was going to go on for hours, but we are actually in a situation where we can give you back, 45 to 50 minutes of your day, so you can enjoy all the culinary treats that, Saratoga Springs has to offer for lunch. And unless anybody has anything additional to bring forward to the committee, our next meeting is November 26th via webcast. Amy will be providing us with the link and the day and the time and so on and so forth as usual. But I would like to ask every member of our group to really think about, thoughts that we can add to our ballooning agenda about ways to improve the emergency health care of children in whatever way makes sense. We've already talked about the quality initiatives that I am hopeful that Maya will be able to come up with. I know she will, because she always comes up with something really good. But there's a lot of brain power around this table, and all of you have specific interest in, and love for our younger patients and making sure that they are as protected as we can, as we can keep them. So please think about thoughts that we can turn into a work project. The department is always pleased when we come up with a work product that, is useful to the youngest citizens of our state, and that's why we exist. So please think about it, put on your thinking caps, and not that you don't have them on already, and we'll go from there. I see Dr. Vonderjat already has a thought.
I just have a question about the data resources that we have. Do we still have the data person that was introduced a few times ago for potential projects and looking at some of the data to drive quality improvement kinds of projects?
So Jacob DeMay continues to be our pediatric data coordinator. Is that your? Yes, coordinator, pediatric data coordinator. So Jacob DeMay, obviously, so he is seated in the data informatics unit. So any reports or requests can go through EMS data. What is it? EMS data. So EMS data at health.ny.gov. And of course, CC me on that so I can follow up on it. So he is the pediatric data coordinator. So yes, he is dedicated to us. However, right, I will say that in other discussions and in other data polls, sometimes the way that the EMS charting standards are and how EMS charts are completed, we need to be mindful of that when we're asking questions, because we can only pull out what's been put in. Yeah. I think that typically ends up being every time that, not just for here, but other work groups and other work that we've done continues to kind of be like, okay, so how should we ask the question, to pull out the most accurate data?
Could I quickly ask, is the data coordinating only for EMS, but is it also for Sparks data from emergency departments and inpatient, going back to the idea that EMS-C is broad?
So for Sparks data and in-hospital data, I believe we have to go through DMAR? Yes. So we would have to prepare a request, and obviously the data informatics unit would assist us with that. Yes.
Okay. Unless there is any other business to transact, I believe we're done for the day. So I'd like to entertain a motion to adjourn until November. Kevin, thank you. Bruce, thank you. We are adjourned. Safe home, everyone who's going home, and I hope many of us will be able to stay for the remainder of the meetings. Take care.